Assalamu alaikum. Our topic today will be about gallstone disease of the gallbladder. Cholecystectomy, this is a surgical operation that includes removal of the gallbladder. It can be done by two methods: minimally invasive method, laparoscopic cholecystectomy, or open surgery by open cholecystectomy. A short right upper transverse incision is made centered on the lateral border of rectus muscle, and the gallbladder is appropriately exposed. Pack are placed on the hepatic flexure of the colon and duodenum and the lesser omentum to ensure a clear view of the anatomy of the porta hepatis. Callot triangle should be dissected and verified to complete dissection for cholecystectomy. The peritoneum is divided close to the wall of the gallbladder, and fat in the callot triangle carefully dissected to expose the cystic artery and cystic duct. The cystic duct is dissected up to common bile duct should be clearly identified. Cystic artery is tied and divided. Whole of triangle of callot should be displaced to ensure the anatomy of the duct, and cystic duct is divided between ligature. Gallbladder is dissected away from the gallbladder bed. Cholecystectomy, which indicates the opening of the common bile duct during the surgical removal of the gallbladder. There are certain indications for cholecystectomy at time of cholecystectomy. So in a situation in which sophisticated preoperative imaging or preoperative cholangiography is not available, it is well to remember the traditional indication for cholecystectomy, which are: first, palpable stone within the common bile duct at time of cholecystectomy; second, jaundice and the history of jaundice or cholangitis; three, dilated common bile duct on preoperative investigation by ultrasound or MRI tests in particularly raised alkaline phosphatase. Late symptoms after cholecystectomy or post-cholecystectomy syndrome. This refers in symptoms that develop in about 15% of patients following cholecystectomy. These patients fail to relieve the symptoms for which the operation has been performed. Such a problem may be related to preoperative symptoms which remain and continue for the postoperative period. These patients require full investigation to confirm diagnosis and exclude presence of stone in common bile duct or cystic duct stump or operative damage to biliary tree. These investigations may include MRCP or ERCP. If a stone found, should be removed from the common bile duct. Management of common bile duct obstruction following cholecystectomy. Patients who develop symptoms either immediately or delayed after cholecystectomy especially if jaundice is present, need urgent investigation. This is especially true for jaundice associated with infection, which means cholangitis. First step in the management include immediate ultrasound, which will demonstrate whether there is intrahepatic or extrahepatic duct dilatation. Anatomy may be needed to be defined by either ERCP or MRCP. The latter investigation will also allow for therapeutic maneuvers such as removal of obstructive stone or insertion of stent across biliary leak. If a fluid collection is present in subhepatic space, drainage catheter may be required, which should be inserted under radiological control. If expert person is not available. At open operation, small biliary leaks will usually resolve spontaneously, especially if there is no distal obstruction. If common bile duct is damaged, the patient should be referred to appropriate expert for reconstruction of the duct. About 15% of injuries of the bile duct are recognized at time of operation. 85% of cases, the injury declares itself post-operatively in the form of persistent leak of bile, if drain had been provided, or biliary peritonitis if such a drain is not provided, or obstructive jaundice, which is usually deepened, severe obstructive jaundice. When the obstruction is incomplete, jaundice is delayed until subsequent fibrosis renders the lumen of the duct stenotic. Any change in bilirubin or suggestion of duct damage require investigation. The nature of bile duct injury should be clarified. Surgical repair and subsequent outcome are related to the level of injury. How to treat these patients? If the patient is debilitated, temporary external drainage should be achieved by passing catheter percutaneously into the intrahepatic ducts. A stent may be passed through stricture at time of ERCP and should be left to be drained into the duodenum. When the general condition of the patient is improved, definitive surgery can be undertaken. And principle of surgical repair is maintenance of ductal length and restoration of biliary drainage. For benign biliary stricture or duct transection, the preferred treatment is Roux-en-Y choledochojejunectomy. For a stricture of a recent onset through which a guide wire can be passed, balloon dilatation with insertion of a stent is an acceptable alternative, provided that the services of an experienced endoscopist are available. The outcome of such surgery is good, may reach up to 90% success rate. Another entity, a stone in the bile duct. Duct stone may occur many years after cholecystectomy or related to development of new pathology like infection of biliary tree by Scarus lumbricoides or Clonerchus sinensis. Any obstruction to flow of the bile can give rise to stasis with the formation of stone within the ducts. Consequence of duct stone is either obstruction to bile flow or infection. with cholangitis. Stones of the bile duct are more often associated with infection of the bile in up to 80% of the cases. Patient may be asymptomatic. It usually has bout of pain, jaundice, and fever. Patient often ill and feels unwell with cholangitis, which means a triad of pain, jaundice, and fever, which sometimes referred to as Charcot triads. Signs of patients with bile duct stone: tenderness may be elicited in the epigastrium and right hypochondrium. In the jaundice patient, it is useful to remember Courvoisier law Ca of the pancreas. In obstruction of the common bile duct due to a stone distension of the gallbladder seldom occur because the organ is already fibrotic. In obstruction by other causes like Ca head of the pancreas, distension of the gallbladder is common. Management of the common bile duct stone. It is essential to determine whether the jaundice is due to a liver disease or diseases within the common bile duct, like sclerosing cholangitis or obstruction of biliary tree, and this can be clarified by ultrasound scan, liver function test, liver biopsy, MRI, or ERCP may delineate the nature of obstruction. Patient may be ill, pus may be present within the biliary tree, liver abscesses may develop. Full supportive measures are required, starting from rehydration, correction of clotting abnormalities, treatment with appropriate broad-spectrum antibiotics. Once the patient resuscitated, relief of obstruction is essential, which can be done through endoscopic papillotomy or combined with sphincterotomy and removal of the stone by using a Dormia basket or a placement of a stent. If stone removal cannot be done, if this technique fails, percutaneous transhepatic cholangiography can be performed to provide drainage and subsequent percutaneous choledocoscopy. Surgery in the form of choledochotomy, which means opening of the common bile duct, may be done. Choledochotomy. When faced with a sick patient whose investigation shows that the causes of cholangitis is a stone in the duct and minimally invasive technique for stone extraction are not available, surgeon may do laparotomy. The aim of surgery is to drain the common bile duct, remove stone by a longitudinal incision in the duct. When the duct is clear of stones, T-tube drain may be inserted into the common bile duct. The long limb of the T-tube is brought outside on the right side of the patient. When the bile becomes clear, the patient has been recovered. A T-tube cholangiogram is performed after 7 to 10 days usually following the operation. If residual stone found, the T-tube should be placed inside for 6 weeks until mature tract is formed, and the retained stone can be removed by percutaneous technique. Another entity is stricture of the bile duct. This arrangement can show us causes of benign biliary stricture. First cause, congenital causes like biliary atresia. Second type of causes, bile duct injury at surgery, as in cholecystectomy, choledochotomy, gastrectomy, hepatic resection, or transplantation. Or inflammatory categories, including stone within the common bile duct, cholangitis, parasitic infestation, pancreatitis, sclerosing cholangitis, radiotherapy. Fourth group, trauma. And fifth group, idiopathic causes for biliary stricture. Radiological investigation for biliary stricture include ultrasound, cholangiography, which can be performed via G-tube if present, ERCP, MRCP, percutaneous transhepatic cholangiography, or CT scan. Primary sclerosing cholangitis is an idiopathic fibrosing inflammatory condition of biliary tree, which affects both intrahepatic and extrahepatic duct. It may be associated with hypergammaglobulinemia. Majority of patients lying between 30 and 60 years of age. There is a male preponderance and strong association with inflammatory bowel disease like ulcerative colitis. Common symptoms including right upper quadrant discomfort, jaundice, which is obstructive in type associated with pruritus, fever, fatigue, and weight loss. The investigation will reveal the obstructive patterns of liver function test with elevation of serum alkaline phosphatase, gamma glutamyl transferase, and a rise in aminotransferase. Bilirubin values can be variable and may be fluctuant. Imaging like MRCP or ERCP may demonstrate stricture, which is usually beading on cholangiography. Liver biopsy is helpful for the diagnosis and may give us a guide in the therapy by excluding liver cirrhosis. Important differential diagnoses are secondary sclerosing cholangitis and cholangiocarcinoma. Medical management with antibiotic, vitamin K, cholestyramine, steroids, and immunosuppressants like azathioprine usually is unsuccessful. Endoscopic stenting of dominant stricture in selected patients with predominantly extrahepatic disease, operative resection may be helpful in certain patients. Otherwise, for patients with liver cirrhosis, liver transplantation is the management of choice. Parasitic infestation of the biliary tree. Biliary tree may be infested by different parasites like biliary ascariasis. Commonly infest the intestine, inhabitant in Asia, Africa, Central America, and these parasites may enter the biliary tree through the ampulla of Vater, causes biliary pain and biliary colic. Complication include stricture, suppurative cholangitis, liver abscess, empyema of the gallbladder. In uncomplicated case, antispasmodic can give to relax the sphincter of Oddi. The worm will be returned to the small intestine, and where antihelminthic drugs will be helpful. Operation may be necessary to remove the worm or deal with complication. Worm can be extracted by ampulla of Vater by ERCP. Another parasite which may infest the common bile duct is Clonorchis sinensis. The disease is endemic in Far East. This is a flukes up to 25 millimeter length. It inhabits the bile duct and intrahepatic biliary ducts. Fibrous thickening of the duct wall may occur. Many cases are asymptomatic. Complications include biliary pain, stone, cholangitis, cirrhosis, choledochotomy and T-tube drainage. In some cases, choledochoduodenostomy may be required. Because of the process is recurring stone formation, acholedoc biliary tree, it had been discussed in previous lectures. Tumors in the biliary ducts, benign neoplasm occur in biliary duct with biliary obstruction, like papilloma, adenoma, multiple biliary papilloma, granular cell myoblastoma, neural tumor, leiomyoma, and endocrine tumors. Also malignant tumors of the bile duct, they are rare. Incidence nowadays may be increasing. Patient presented with jaundice, weight loss. Diagnosis can be done by ultrasound, CT scan. Jaundice can be relieved by stenting. Surgical excision is possible in 5% of the cases, but unfortunately prognosis is poor. Carcinoma of the gallbladder, it is a rare disease, extremely variable by geographical region and racial ethnic group. The highest incidence may be seen in Chile, American Indians, and part of North Indians, where it occurs in about 9% of biliary tract disease. Western practice, gallbladder cancer accounts for less than 1% of the new cancer diagnosis. Patients are usually old, in their 60s or 70s, and etiology is unclear. But there may be an association with pre-existing gallstone disease. Calcification of the gallbladder is associated with cancer in 10 to 25% of the cases. Infection may promote development of cancer, as the risk of carcinoma in typhoid carrier is significantly increased. Pathologically speaking, majority of cases are adenocarcinoma in 90% of the cases. Carcinoma are difficult to be differentiated from chronic cholecystitis. The tumor is most commonly nodular and infiltrative, with thickening of the gallbladder wall, which may be extend to the whole gallbladder. Tumor may spread by direct extension into liver or peritoneal cavity, or lymphatics and neural plexuses are affected. Majority of these tumors are advanced on time of presentation. Clinically speaking, patient may be asymptomatic at time of diagnosis. If symptoms are present, they are usually indistinguishable from benign gallbladder disease, like biliary colic or cholecystitis, particularly in the older patient. Jaundice, anorexia, and palpable mass are late sign. Investigation, laboratory finding may be consistent with the biliary obstruction or non-specific findings like anemia, leukocytosis, elevation liver function test, increased ESR or C-reactive protein. The level of serum CA19-9 is elevated in 80% of patients. And this CA19-9 is tumor marker for the carcinoma of the gallbladder and biliary tree. Diagnosis is made on ultrasonography, which can be defined by also CT scan. Percutaneous biopsy will confirm the histological diagnosis. Laparoscopy may be useful in some cases as a staging for the disease. Treatment. Occasionally, diagnosis is made by histological examination of the gallbladder removed for benign gallstone disease. In early stage disease confirmed to mucosa or muscle of the gallbladder, this is cholecystectomy is enough. No further treatment is indicated. However, for transmural disease, a radical in-block resection of gallbladder, fossa, and surrounding liver along the regional lymph node should be performed. the disease has a very poor prognosis with median survival less than 6 months and 5-year survival of 5%. Adjuvant chemotherapy is unproven effects.